Okay, when you're giving IVs, again, it's important to remember that this is a sterile procedure, and not kind of sort of sterile procedure, but you need to maintain sterile technique at all time. You'll want to monitor the flow rate of the IV to make sure it's going according to what the physician orders, because the physician doesn't say, well, give him some IVs. He or she will determine what the rate is the patient's going to get them according to their clinical situation. When you're caring for an IV, the tubing gets changed every 72 hours, and the bottle gets changed every 24 hours, whether it's empty or not. One of the things you'll need to do for the NCLEX exam is to be able to calculate IV flow rates. And there's a couple of ways you can do it. If the physician orders a certain amount of solution in a certain number of hours, what you do is you take the total solution, for example, 1,000 cc's, and he or she, the physician, says that they want it to run in 8 hours. So you would put 1,000 divided by 8, and you would make that IV solution run at 125 milliliters per hour. If you have the total volume, again, and you need to get the drops per minute, you'll use a slightly different formula. This formula is the total volume times the drop factor over the time in minutes. And let's just say again, the physician wants the total volume to be 1,000 cc's. You are using equipment where the drop factor is 15, so you will take 1,000 cc's times 15, and you will divide that number by the time in minutes. And one of the frequent errors that nursing students make is they forget to put the time into minutes. So if the physician wants it over 8 hours, you would multiply the 8 times 60 to get 480. So it would be the 1,000 cc's, which is the total volume, times the drop factor, which in this particular case is 15. You'll get that off the equipment, divided by 480. So you would regulate that IV to go at 31 drops per minute in order to infuse it as ordered by the physician. Let's talk about some of the complications of peripheral IVs that patients can experience. Probably the most common is infiltration. And infiltration is when the IV access equipment comes out of the vessel and goes into the surrounding tissues. And the signs and symptoms you will see then make sense because the IV fluids are then flowing into tissues rather than into the vessel. You will see the skin will be cool because the IV solution is cooler. It's like room air compared to body temperature, which is at least 98.6. There will be swelling again because the fluid is going into the tissue. The patient will complain of pain, and there may be a decrease in the IV flow rate. One of the best ways to figure out whether or not your patient has an infiltrated IV is to put a tourniquet on the patient's arm. Let's say I have my IV in this area. I will put a tourniquet above the insertion site, and I will tighten it. And when I tighten the tourniquet, the IV should stop because I have blocked off the IV access. If the IV continues to flow, that means that the IV solution is going into the surrounding tissues, and that IV should be discontinued and restarted, usually on the other arm. So what you will do with implementation for a infiltrated IV is you will discontinue the IV. A lot of times it will be very helpful and comforting to the patient to put a warm compress there. You will elevate the arm because, again, remember, gravity is your friend. It will help the solution drain from the tissue. And you will start the IV at a new site proximal to the infiltrated site. Another complication you'll see with peripheral IVs is phlebitis or thrombophlebitis. What you'll see here, this is an inflammation of the blood vessel. Again, the symptoms make sense. There'll be redness. The area will be warm to touch. It will be tender. There'll be swelling in the area. And when you're looking at the patient's lab values, there may be leukocytosis. Remember, normal white blood cells is 5,000 to 10,000. So anything above 10,000 is leukocytosis. If you suspect that the patient has phlebitis or thrombophlebitis, what you will do is, again, you will discontinue the IV. In this case, you will provide warm, moist compresses and restart the IV in a new site. And again, usually you will use the opposite extremity. Another complication of a peripheral IV is a hematoma. A hematoma, you will see ecchymosis or swelling or discoloration, bruising. There'll be swelling and perhaps leakage of blood. The implementation of the nursing care you will do for a hematoma, again, you discontinue the IV, you will apply pressure to the site, you will provide an ice bag for at least 24 hours, and you will restart the IV in the opposite extremity. One of the other complications you'll see with the peripheral IV is clotting. That's where the vessel clots off. You will find that out because there is many times a decrease in the IV flow rate. And again, we want to make sure our patients' IV fluids are on time, so we will monitor them frequently. One of the other things you many times will see is there'll be a backflow of blood into the tubing. So when you look at the patient and the tubing, you see blood in the tubing. That should not be there. It should be clear because of the IV fluids running through it. What the implementation is, if the vessel becomes clotted off, is again, you will discontinue the IV. You do not irrigate it. You do not milk it. You do not increase the flow of the IV rate. You do not elevate the bag and hang it higher and hopefully blow that thrombus out of the end of your access device. You do not aspirate it. One of the things that can be used is urokinase, but most of the time the IV will be discontinued and started in another site. And again, be well aware of the things you don't do. You may see these things done in practice, but for the NCLEX exam, these are things that would be contraindicated. Let's talk about central venous access devices. And the first one we're going to talk about is a PICC, or what they call a PICC line. This is a peripherally inserted central catheter. Usually they will do a venipuncture above or below the antecubital fossa into the basilic, the cephalic, or the axillary veins of the dominant arm. And the reason they use the dominant arm, you might say, well, wait a minute, why the dominant arm? Why don't we want to use the other one? They use the dominant arm because it encourages blood flow and reduces the risk of dependent edema. And what they do is the tip of the catheter goes into the superior vena cava or the brachiocephalic veins. And PICC lines may stay in place up to 6 months. Now, complications of PICC lines. These are the type of bad things that can happen with this type of access device. There may be a pneumothorax, which is the lung decompresses and collapses, again because of some change in pressure. There may be dysrhythmias or altered cardiac rhythm. The patient may experience thrombophlebitis. There may be nerve or tendon damage. The patient may experience respiratory distress, or there may be an embolism in the catheter. So what you will do for this type of central venous access device is the dressing is changed about 2 to 3 times per week. Again, remember we said they can stay in place up to 6 months. So we'll change the dressing 2 or 3 times a week with either or when it becomes wet or when it becomes non-occlusive. So you change it kind of PRN if something bad happens to it, or 2 to 3 times a week if everything appears to be going well, because you don't want the area to become infected. You will flush it with 2 cc's of normal saline, followed by 1 cc of heparin flush, which is 11 units per milliliter heparin solution. And you put it into each lumen of the PICC line. Another type of central venous access device is called a midline catheter, or MLC. These what they do is they put them in and they increase in size. You put in something and it kind of like it swells up, at least 2 gauges, and 2 hours after insertion it also becomes softer. So it is relatively small and firm when it goes in. It becomes larger and softer after it's been in a while. What they do to put in the midline catheter is they do a venipuncture 2 to 3 finger breaths above the antecubital fossa, or 1 finger breath below the antecubital fossa. Again, it goes into the cephalic, the basilic, or the median cubital vein. And what they do then is they thread the tip of the catheter between the antecubital area and the head of the clavicle. And these type of catheters, the midline catheters, can stay in place from 1 to 8 weeks. Not quite as long as the PICC lines, but a pretty long time. The type of complications you may see with the midline catheter are thrombosis. The patient may experience phlebitis or inflammation of the vein. They may experience air embolism. The area may become infected, or they may have vascular perforation. The type of nursing care you will do for midline catheters. Again, you will change the dressing 2 to 3 times per week, or when it needs to be changed. Either it becomes wet or non-occlusive, which is exactly the same thing we did for the PICC lines. You will flush the line after each infusion or every 12 hours, and what you use is 5 to 10 milliliters of normal saline followed by 1 cc of Heplock. Again, that's the heparin solution, 11 units per milliliter, and it goes into each lumen. And again, this should be done every 12 hours or after each infusion. And you want to make sure that the catheter is anchored securely so it doesn't become dislodged or perforate the vessel. Another type of you have percutaneous catheters, and this type of catheter, there's a special type of insertion that is done. And again, this is a frequently tested topic on NCLEX. What you do for this is you will place the patient in a head-low position. They are supine with their head low. The reason this is done is it dilates the vessel and prevents an air embolism. The patient, while the procedure being done, is told to turn their head away from the procedure. So if this is happening on my right side, as a patient, I should be looking over to the left side. You tell the patient when the catheter is inserted to perform the Valsalva maneuver. Remember, that's the straining or bearing down, pushing against or forcing against a closed glottis. Antibiotic ointment is applied, and then a translucent dressing is applied so you can kind of see what's going on under the dressing. This type of placement of catheter is verified by X-ray. That's how they make sure that it is positioned where it should be. And then each lumen is secured with a Luralock cap and labeled to indicate whether it's the proximal, whether it's the middle, or the distal lumen. Again, each one is labeled so you know which one is which. The type of nursing care you will use with this type of catheter is you will change the catheter every 4 weeks. The site is changed every 4 weeks, so it's not kept in place as long as the PICC line or the midline catheter. You'll change the tubing every 24 hours. Again, this helps prevent infection. You will flush each lumen with a diluted heparin solution twice a day, and after every infusion, after every specimen is withdrawn, and just before it is discontinued. And again, the dressing change, 2 to 3 times a week. When you are doing, to kind of go back a minute for the flushing, you would never force it. If resistance is met, you would notify the physician. You would never do a flush and force anything through. If it doesn't go through easily, you would notify the physician. Again, when you do the dressing change 2 to 3 times a week, in this particular case, you put the patient, again, in a special position. It's not as easy a procedure as it was with the PICC line or the midline catheter. When you're changing the dressing, you will place the patient in a low Fowler's position, 15 to 30 degrees head of the bed elevated. The nurse and the patient both wear masks, and then you use alcohol and then iodine to swab the area. And again, this is done to prevent infection.